ankle and foot. Paul.
Thank you very much. Hello Amsterdam. Thank you very much for having me. It's a huge honour to be put in the same group as some of our esteemed colleagues. Wolfgang, who I said is a Jedi Master of Shockwave, and here I am as a little physiotherapist also being on the same docket, so I'm very pleased to be here. So we're going to talk about the foot and ankle. I hope this is going to work for me. So I'm going to tell you a little bit about myself, because obviously Google doesn't do it for you. I'm a specialist physiotherapist and a sports medicine practitioner. I ended up doing 3 degrees and 2 masters, and I'm currently doing a PhD. Reason being is that I was a professional athlete for 16 years, kayaking, nothing too special. My dad's a professor, my mum's high up in education, and they wouldn't let me just play around in a piece of fiberglass, so I just studied lots to keep them happy. I'm a shockwave therapy educator for over 10 years. I've been instilling a shockwave program in the UK, which I'm very proud of. I've got 2 books, best-selling author on Amazon, which is good. In the UK, I'm an independent prescriber, which means I'm essentially a drug dealer, which you'll all be happy about here. I'm an injection therapist, I'm a sports scientist, and my PhD is looking at shockwaves and sports performance, which is not pathology, you would say, but actually, and I'm going to share that with you this afternoon, so we won't spoil that too much just now. So, when I was asked to do a talk on foot and ankle conditions, I sought out a nice systematic review from this very year, and they had 24 studies, 12 RCTs and 12 case series, and they considered plantar fasciitis, Achilles tendinopathy and Morton's neuroma as 3 indications that were very well studied and understood. But this is my bugbear, and Wolfgang says it also. They say it's a safe and effective treatment option, but requires more scientific study. Now, this really burns my toast when they say that, because there are so many studies. And if you look here, just on a quick Google Scholar search for shockwave and either Morton's neuroma, Achilles tendinopathy, or plantar fasciitis, these are the number of results it returns back. Now, of course, this isn't a perfect look into how many studies are on each topic, but if you use the same criteria, shockwave therapy and the indication, we're getting huge numbers of results. And so why we need to continue to keep proving that shockwave works for the naysayers is beyond me. And there may be people in this room who are new to shockwave and they've come here to think, well, does it work or doesn't it? I think my colleagues have done a very, very good job at showing you exactly what it can do. And now what we're going to do is we're going to look at these 4 conditions. The 4th one is ankle sprains. And I see a lot of ankle sprains, and I'm going to spend more time on that. You can go away and read as much as you want on plantar fasciitis, on Morton's neuroma, or on Achilles tendinopathy. That is easy to do. You don't need me to fly in from the UK to talk to you about that. But I'm going to look from a very physiotherapy and shockwave positions on ankle sprains, which I hope you find very interesting. So, plantar fasciopathy. Shockwave has beneficial effects on the pain. We have hyperstimulation anesthesia. We basically disturb the nerve signals so pain is reduced. So your patient gets off the couch after having shockwave and they're walking around going, this has been a miracle. But you have to tell them, within 2 hours to 2 days, that's going to wear off and you're going to think that it didn't work. You have to wait for the results. Now, I personally treat 5 or 6 times, and I'm going to show you my protocol in a second. And the reason I like 6 sessions, and I know the data suggests between 3 and 5, is that substance P, which I always would like to think stands for pain, but substance P increases initially when you start using shockwave, and at 6 weeks it's come right down below its previous baseline. So your patient reports to you that things are feeling a lot better at 6 weeks. And as a physiotherapist, I like to go on the journey with them. I like to see them at that point, and so we can both agree that things have happened. And anecdotally, whilst we have to wait 3 months for the maximising of the effect, at 6 weeks, between the 5th week and the 6th week, is the big step change in how the patient feels. And that's been my anecdotal experience. Maybe you might share something different with me later on. So, shockwave could be performed with no side effects, an alternative to conventional treatment, and this is a meta-analysis of 11 RCTs, which totaled 668 subjects. We just do not need more proof that it works. So here's my protocol. You don't need to use this. We're going to share the slides with you, but take pictures, no problem. So 5 to 6 sessions of radial pressure wave to the gastrocnemius. We do 2,000 shots, around 2 to 2.5 bar pressure, and a nice high hertz, 14 hertz. Well, why do we want to use high hertz? Because we get a greater stimulation anesthesia from a higher hertz. A TENS machine, used purely for pain, works at about 50 hertz. And if you're just doing radial pressure wave at like 10, 8 hertz, you're not really stimulating those nerves in the same way. So I use a higher hertz, sometimes all the way up to 21 hertz if my patient is suffering. Then we do focus shockwave to the most painful part. This was illustrated very nicely by Wolfie before, where he uses a similar thing. So if you imagine a dartboard or a target, shooting target, I think of the bullseye as where I'm going to use my focus shockwave, and everything else around the outside is where I'm going to use my radial pressure wave. So we put the two together. Then we've got exercises, right? For physios, so we like to give some exercises. So we want to work the intrinsic muscles of the foot by grabbing a towel on the floor with our toes. We want to do some nice stretching for the gastrocnemius and the soleus. Do not forget the soleus. There's a Strasbourg sock, you may have different terms for it, but it's a very beautiful sock that you put all the way up to just below the knee. I refer to it as being a very good prophylactic. You're not going to make babies when you're wearing a Strasbourg sock, it's very unattractive. And then a nice cushioned insole inside the shoe to prevent you from keeping bashing that plantar fascia in your hard work shoes. And then calf raises. Fairly new science suggests that the plantar fascia, whilst we know it's a connective tissue, responds very, very similar to an Achilles tendon or a patella tendon when you load it. So don't be afraid, once the patient's got their pain a bit more under control, to start loading that plantar fascia with calf raises. So Morton's neuroma. So this is a peripheral neuropathy, a separate peripheral neural condition. And there's some really, really good studies about Morton's neuroma. The thing that I don't like about the studies is the metrics they use seem to all be around pain. They talk about the fact that pain was reduced, the visual analog scale pain scores were reduced significantly. Shockwave is not a pain treatment, so what else is going on? But the way they report it is that the main metric was reducing pain. They've also got the ankle functional score was significantly improved, so at least that's in there. But this is over 4 weeks. There's a very, very quick change. I don't know how many of you have used shockwave, typically focus shockwave on Morton's neuroma, but it's very, very quick to respond. Your patients are very, very happy. And then what we do is focus shockwave directly on the most painful part. There isn't a massive amount you can then do with radial, maybe a bit into the calf, but I tend not to do that. And then a little metatarsal dome, you know, just in behind the medial transverse arch, just to spread the toes a little bit, slightly wider fitting shoes, and we do some distal mobilisations of the foot and ankle. We make sure the foot and ankle is working very, very well. And what's quite nice is big toe extensions. I get people sat watching the TV, just putting their big toe up, just to stretch out at the underside of the foot. And we get some really, really good results through doing this. Now the Achilles tendon. I would sometimes say the Achilles tendon along with plantar fasciitis are the poster children of shockwave. There's so many studies, very, very well understood. But here, just 2 years ago, a systematic review of 14 full-text studies, 7 RCTs, shockwave to an attended loading program at mid-portion Achilles tendinopathy has a clinically important improvement from a 2022 study. So we've got lots of really recent studies, and there's so much that shockwave can offer, it kind of mind boggles that we're still looking at the Achilles tendon in 2022 and not branching out to other areas, which I know lots of people are. But the Achilles tendon responds really, really well. And just to go along with the theme, I do radial pressure wave, 2,000 shots between 2 and 2.5 bar pressure, all up and down the gastrocnemius. There are some really good studies that show that if you actually work on the trigger points in these calf muscles, you significantly improve the result that you get from just treating the tissues. Remember, what shockwave is doing is creating a cellular response at the point where the pathology exists. But that pathology came about for a reason. And the reason is normally somewhere else in the chain. So if you just choose to treat the pathology and just look through the eye of a needle, what are you doing? You're repairing it just so the body can undo that work again, because you didn't look at the biomechanics, you didn't look at the rest of the calf muscle, and you didn't treat the body as a whole. Therefore, yes, you will make a difference to that piece of pathology, but the reason that came about has not been addressed. So, we do radial pressure wave also to the length of the Achilles. It's actually a really long tendon, and we use our focus shockwave directly on the pathological area, which we ultrasound scan, we mark with a pen, and then we spend our time there. And the loading program is really important. Isometric loading, which is a high muscle contraction with zero joint movement, so balancing on your tiptoes in this case, has been proven very, very nicely to reduce pain over 2 weeks. The key factor about isometric loading is you must only do it every other day. There is a 36-hour latent response between doing those heavy lifts, and if you do it too often, you'll end up with protein degradation, you'll end up with a worse tendon than you had before. So the loading program is absolutely paramount that you're doing all of this every other day. So 3 times a week is great. So we do 2 weeks of isometric holds. Then from week 3 to week 6, we do heavy, slow resistance. This is Cook and Purdon's work in Australia. Heavy, you must be loaded, and it must be slow. So we'll be coming up for 6 seconds, no stopping at the top, and we come down for 6 seconds. We keep the tendon under a high load, and we move slowly under a heavy weight, and that has a significant collagen turnover, a significant amount of protein synthesis, and we are really delivering what that tendon needs in terms of our graded exercise program. And then, from week 7 or 8 is when you start looking into the eccentric loading. Eccentric loading has been probably the most common form of tendon loading for a long time. I think it's a very high level of tendon loading. If you're dealing with athletes, yes. If you're dealing with the general public, I would definitely go isometric, then heavy slow resistance, then eccentrics at the end. I think it's an important point. So, I bring you on to the lateral ankle sprains. So, this can be an acute presentation. So where does shockwave fit into that? Does it have a role? Because automatically people think, well, if I'm going to, for the first 72 hours after an acute injury, your body is brilliant. It is the most amazing tool of repair. So why would we then come in and involve something that is aiming at stimulating repair? Early on is a pro-inflammatory response, possibly later on is an anti-inflammatory response. But why would we do that into an acute ankle? Well, the point is perhaps you don't go straight for that pathology. Perhaps you look at the rest of the body. So the effects after an ankle sprain are, we've got reduced sagittal movement in the hip, knee and ankle. This is very well understood. Doherty 2016 does a nice study if you want to read about that. So we've actually reduced the movement higher up the chain. We have a problem that has been induced because we rolled our ankle. We've also got an increase in tibialis posterior activity. And we've got reduced peroneus longus and actually tibialis anterior activity. So we've got these competing muscles that should be working synchronized in a synchronized fashion. Now suddenly they're all out of kilter, and we need to understand that and address that. And of course you've got reduced reflexes in terms of your neural proprioception. So not only do we have maybe anterior talofibular ligament and the calcaneal ligament are now potentially torn grade 1, 2 or destroyed at grade 3, we have all these other reciprocal issues going on. So if we want our ankle sprain person to get better, it's not good enough just to say we'll try and fix the ligament. We've got all these other problems which actually become a much bigger issue once the ligament is fixed, because you will always have lateral ankle, chronic ankle instability if you don't address these issues. So if we think about the issues that we've got reduced joint support, we've got reduced firing mechanisms, we've got reduced proprioception, reduced central activity, resulting in a delay of our message to the ankle, and we've got less functional support. So we've got something where we've destroyed some ligaments, or at least hurt them, but now we've got this thing that just doesn't work very well. And that really radiates right up the leg. So we've got increased tibialis posterior activation and decreased peroneus longus activation. The stirrups of the foot that would normally be working together, that synchronicity is now destroyed. So if we've got tibialis posterior, which is going to create inversion of the foot, and it upregulates its activity, peroneus longus, which is responsible for the opposite, eversion, and that's reduced. Those muscles need to be taught to co-activate, and the timing of that needs to be really important. So historically, rehabilitation, certainly in the UK, and from what I've read everywhere else as well, has thought, well, I've destroyed the ligaments on the outside of my ankle, so if I really build up the peroneal muscles, then surely they'll take over as that ligament support. So everyone's been focusing on this kind of peroneus longus activity. But if you think about the attachment of peroneus longus, it comes under the foot, attaches on the inside, and actually pulls you into more pronation if you increase the activity. And what you've got is tibialis posterior is up in its activity, so that comes round to the other side, and that would actually be helping to maintain some sort of arch support. And so we've got this, I think, all wrong for many years. So what we do know, if we go to the data, is shockwave can reduce spasticity, and we've got a nice talk coming afterwards, so I'm not going to get too much into that. But if we take spasticity as a very, very tight muscle, and we try and understand that shockwave might be able to reduce some tension in muscle, then we've got an opportunity here to start to adjust the differences between the either side of that stirrup. We know that shockwave can improve the recovery of ankle sprains, a 2022 paper by Lee. We've got a fairly good idea from animal models that shockwave improves muscle recovery from Zisler and Norton-Nicola. And we know that shockwave can improve peripheral nerve function. So if we know we've got a nerve deficit, both centrally and locally, if we know that we've got a muscle deficit, and we know that we've got potentially a very, very tight muscle and a not so tight muscle, then we should be using shockwave in all these different areas. So, as an idea of what I do, tibialis posterior gets radial shockwave, we calf muscle trigger point radial shockwave. Later on, we will attend to the peroneus longus once we start to see in our on-table physical assessment that we're starting to get a little bit of unity between those two muscles, and also tibialis anterior. So what we do here is about 2 bar pressure, 12 hertz and 2,000 shocks into those muscles. You'll be 6-7 minutes maybe maximum. Focus shockwave, when the tissues are starting to look like their healing from the natural body processes is slowing down, you can introduce a bit of external healing, possibly to the ATFL, the anterior talofibular ligament, and the calcaneofibular ligament, just to stir that along, but you wouldn't do it too early. Now, I say there is a study by Lee that looks at this and suggests it works. I would say that if you get those ankle patients that come to you, because let's face it, most people roll their ankle and they don't really present for 2 to 6 weeks, right? They think it's going to go away, they hobble around. So once you get to the chronic stage, particularly if people are 4-6 months into chronic ankle instability, this then becomes the primary choice, because focus shockwave will actually almost kickstart that early body intervention. You almost recreate the acute mechanism again, but without causing any damage, so you can then speed up the recovery. And I don't know how many of you have looked into EMTT, but the ability for EMTT to reduce down the inflammation and reduce pain in that area really helps you to get the person onto their rehab program. So, in conclusion, I think that we've got a lot of scientific evidence, despite the last chapter or the last paragraph always saying in a lot of scientific studies, but we need more information. I think we've got significantly, not potentially, I've hedged my bets here, faster patient outcomes if we can utilise this technology. I think you must combine it with the appropriate exercises, and you must be looking further up the chain to say, well, where else could we use this great technology in order to make a change to something that we understand? And if you work with the anatomy and physiology, if you're using things like very good clinical skills, or you're using ultrasound technology to actually pinpoint where the problem is, then your ability to create better outcomes will go through the roof. Ladies and gentlemen, it's been an absolute pleasure talking to you for the first time. Thank you very much.
Thank you very much.